one more minute and we'll get started here. Molly, what does the audience look like? Are we nearing our?
We're nearing about 40 attendees right now.
Okay, perfect. We'll give it about another minute and then we'll get started.
Yeah, I just picked up my mother from the airport yesterday and it was a zoo. So mandatory vaccinations are a good idea.
Aye. And look, we have the safe air to look forward to.
Yeah.
Well, Josh, I just heard from friends in Canada that you can't fly in Canada now unless you show full vaccination with the airlines.
Yeah, my boss was just in New York. She was like, you can't get into a restaurant without a vaccine.
Right.
And most of Europe
Right.
too. So.
All right, so I think we're ready to get started here. Good morning, everyone, and thanks for joining us today. My name's Peoples-Swearingen. I will be your moderator. I'm an account executive here at Hennepin Healthcare. And as part of our annual focus on community engagement and involvement, we actually, Hennepin Healthcare is really pleased to announce these webinars. We've presented several of them already, but today our focus is going to be on returning to school amid COVID. Along with our partners, we have both Gallagher Consulting here, and we also have the Orono School District as our special guest to kind of talk about their engagement with us. They are a community partner and used our testing services last year. So today's discussion will center around the challenge that most schools face today. How do we keep our schools open, right? And with very limited guidance and not having a roadmap from CDC or MDH, you're kind of on your own. But what we want to accomplish is really to arm you with some tools and resources that you can lean on to help in your decision making, because the ultimate goal is to have safe and healthy environment for our students and staff, and we're here to help with that solution. Let me present our presenters, but before I do that, just some housekeeping. The chat box is available for you to use for general view, so the entire audience will have access to that. I may be putting some links in there for you for some of the details that we're sharing today. Otherwise, the Q&A box is to be used for your questions that will be directed to the panelists. And thanks again for that. And let me go on to our presenters. Pleased to announce that Rebecca Zadroga, one of our own physicians here at Hennepin Healthcare, is part of our panel today. Glen Hansen, Medical Director of Microbiology, and also set up all of our COVID testing at the hospital, along with Rebecca, Dr. Zadroga. They both are actually very active in our COVID outreach and assist me and my team with outreach to the community. Stacene Maroushek is also a physician and a pediatrician with the Infectious Disease Department. And then we have Josh Gramling, who actually manages our occupational health and wellness group here at Hennepin Healthcare, and he'll be sharing some information about how we have managed COVID amongst our workforce. Heather Eastman is also our consultant and a senior consultant with Gallagher, as I mentioned. She's in the human resources, so she will add some insight around some of the challenges there. And then final is Kristine Flesher. She's the superintendent of the Orono School District. She's worked with us for over a year with testing. So we're happy to share her case study and lessons learned from COVID. So today's topics, we're going to just review the current state of the virus, look at some of the vaccines that we have in play. I know we'll be talking about the variants as well. We'll look at some of the return to school employee testing options that we have, as well as some additional considerations that would be of value to this audience. The Orono School District case study will be presented by Dr. Flesher, and then the COVID-19 and flu program that we host here at Hennepin Healthcare will be presented by Josh. And then we'll go on to Q&A. We're going to try to leave about 20 minutes for Q&A because we know that there's burning questions from everyone in the audience. So to get started, we want to do 2 poll questions just so we kind of understand what the concerns are of this group. So Molly, would you move to the next slide when you're done with this one? And we'll share the poll results with everybody. So you have 3 options for this question, and we will give you a few minutes to complete that poll. And then we'll be sharing a diagram to show you what the poll results are from our audience. We should be nearing the end of the polling. Thank you for participating in this. It provides us with some direction. There we go. So this is good news that most people are feeling somewhat confident that they're on the right track. And let's move on to our second poll question. Again, this will provide some insight into what the audience is thinking about in terms of how they manage their buildings. This is very interesting. I'm curious to know the outcome here. So again, this is all over the map, which is good to a certain extent because it gives us a good way to discuss some of these options today. But it looks like required masking is dominant. It's the predominant policy going forward. All right. And without further ado, we will let Dr. Zadroga start this presentation.
So good morning, everyone. I want to indicate first just a little bit of a reminder. There's a lot of folks talking this morning. I'm an adult infectious disease doctor, but I've been involved at HCMC in a lot of the COVID policies and actually treatment of patients here since this whole pandemic began. And on a personal note, my mother was an educator for many, many years. She was actually my high school and middle school principal. So education is near and dear to my heart, and it's something I do on a daily basis. So I'm very glad to be participating in this webinar, and I thank you in the audience all very much for your interest. The poll questions were of interest to me because hopefully we can allay some of your concerns or fears or answer some of the questions that you have. So if there's one thing that's obvious about COVID is that it's changing rapidly and we don't know exactly what's going to happen. This test and this information that I have up on the screen right now is publicly available by the Department of Health. And as you can see, it's about 3 weeks old now, but what I'm trying to isolate and show with this map is how the positivity and the testing just within the last month has changed dramatically in different parts of the state. So the most important thing to note from left to right is obviously the intensity of the positive testing has gone up. And there are some counties that are particularly more prevalent in terms of positive testing across the board. And I anticipate that we will get another spike coming here in the next month or two, depending on the Delta variant and so forth. And if you wanted to look for specific counties, you can see that below, but it's more of a visual sort of cue for you guys to follow. And on the next slide, what you will see is how these cases in the state are distributed. And what I think is really important to show with both of these graphs is two things. First of all, that the vast majority of cases of COVID currently, we actually do not know where people contracted the virus. So you cannot do contact tracing and say you got it from Joe Schmo or from the next person. We actually have no idea where people contracted it. And so when there's an argument to be said about, well, I'm not around people that have COVID, you have to keep in mind that statistically that actually doesn't hold up, and you have to be mindful that it can come from anywhere. The other thing that's really important to note with this is that the vast majority of the cases that we're seeing in COVID right now are in the young, between about the age of about 15 to about the age of 24. And that's probably for two reasons, partly because those are the unvaccinated folks, but also because they're also much more efficient transmitters. And of course, this is going to be right up the alley of the type of people that you are caring for in your jobs. And then lastly, what I'd like to highlight, and so as a reminder to everybody in the group, is how COVID is actually transmitted. And COVID is complex in its transmission. There's lots of different ways that it can spread from person to person, and it's important to get some definitions out there. So a droplet transmission is when you have secretions that come from coughing or sneezing. They're fairly large particulates in size, and they usually only travel about 6 feet or a little bit more, which is where that 6 foot distance came out for social distancing. And the vast majority of COVID is transmitted through droplets. There is maybe some evidence that there's some aerosol spread, which are much, much smaller particulates that will travel much larger distances. We're talking across rooms or across hallways. And then earlier in the pandemic, we were noticing that the COVID would live on hard surfaces, and you could pick it up by touching hard surfaces and passing it from person to person after going from the hard surface to your mouth or to your mucous membranes. And that is absolutely still an important method of transmission for COVID. And it's very difficult to give you a specific number on this because each surface has a different transmission rate and ability to hold the virus. But generally speaking, the harder the material, the longer the virus can stay living on that surface. And then just so the audience is aware that there's a lot of other routes where the virus is transmitted. And currently fecal matter is being used in a lot of surveillance to actually identify population levels of infection rates, even though we're not routinely looking for that virus in fecal matter of individuals. It has a very important public health role. And so with that, I think we'll get moving with a little bit more of the science here. Go ahead, Dr. Hansen.
Sure. So thank you, Dr. Zadroga. So my name, by way of brief introduction, folks, thank you for your time this morning. My name is Glen Hansen. I'm the Director of Microbiology at Hennepin County. I have PhDs in both microbiology and immunology, and for the last 2 years have really focused on our COVID testing scene at Hennepin, which quite frankly are 2 years that I'd like back. But I thought I'd spend some time this morning just showing you why we care about the variants. There's lots of discussions about the variants in the news. And so I thought I'd just spend a couple minutes explaining what these variants are. So this is just a busy slide showing you all the different variants that have arisen. And in fact, we knew early in Wuhan that shortly after January, February, the virus, within the 2 months of it being described, the virus had changed. So we are no longer dealing with the same virus that we saw early on, and you're seeing all these variants. The variants are now being named after Greek alphabet letters, alpha, delta, lambda, you might have heard of. Part of that is some political pressure so that we don't highlight the UK, Brazil, South Africa, and we're now naming these after Greek letters. So if you want to advance to the next slide, these were our traditional 4 that arised. And you can see that they were originally given numbers. B117 was the UK. Then we had the variant out of South Africa, Brazil, and then the one on the far right was a California variant. And then the next click will show us our current friend, the Delta variant. And so I want to spend next slide, if you move to the next slide. This is what happens with COVID-19. COVID-19 here is represented in red, and your human cells, which are called ACE2 receptors, are represented in green. And we really rely on a vaccination strategy to put an antibody in place shown by red here. And this is the traditional model. We throw a vaccine, your immune system responds, and it creates antibodies, and it blocks these attachment points. What's happening with the variants will be shown on the next slide here, if we move to the next slide. So this is a busy slide, but if you look at the bottom, the slides on the top left and the bottom left, the top left, the virus exists in a function with 3 proteins on the surface that we call protomers. The top left was the native conformation of the virus. As the virus develops variants, what happens is these protomers open, which you can see on the top right slide. And every variant that we get with the mutation in the spike protein allows this conformation to open different. So for those of you that deal with primary school, and I've got a 6-year-old at home, so he's a Bakugan freak, and you know how these things open and close and so forth. It's the same strategy with COVID-19. And you can see on the bottom left screen, when these viruses open, they create additional attachment points to our cells. And this, in fact, is the rationale behind the 3rd booster shot, which is to saturate that blocking with greater antibody response to prevent these cells from attaching. So the next slide will just show you some of the chemistry that we've seen with these. All of these spike proteins start to open. And if I was part of your biochemistry or chemistry high school classes, I would note the slide on the right, and we would say, hey, there's a D to a G. And if I was part of your student body, I would raise my hand and said, teacher, when am I ever going to need to know about glutamic acid and glycine? Well, welcome to 2021, folks, with COVID, because what we're seeing are small amino acid changes in the head of the protein that allow that protein to open. And when it opens, it gives greater transmissibility because it binds at higher effect. What the CDC and the NIH is studying is how these variants affect the immune response. That's the big question. We know that the variants increase spread, and I'm going to show you that on the next slide. But if you're wondering what the concern is with the variants, the way that they test it is they will take blood from those of you that are vaccinated, and they'll bring it into the lab with us. Then we'll grab the variant and we'll expose the variant to blood. And the blood presumably has all of the antibodies associated with your immune response. And what we are looking for is, in the setting of variants, how easy does the virus enter the cell? How easy does it enter the cell? It doesn't tell us about whether or not you're going to get sick, whether or not you're going to get hospitalized, but what it tells us is the virus entering the cell easier? And that's what we're seeing with a lot of the variants. Next slide, please. So this is just an example to show you all of the different lineages on a map of all the different variants that we've seen, including the Delta variant, which came out of India. Next slide, please. And this is really the money slide that now people are trying to explain in a very geographical way, a very visual way, where you can see how on the top, the original COVID-19 strain would have an R0 value, which is a measure of transmissibility, and every individual case would affect 3. That was higher than what we saw with both Ebola and flu of 1918, and we're now seeing this lineage advance somewhere between where we see with chickenpox and where we see with highly transmissible flu. And we know now that the Delta strain, a single infection can infect 7 other people, which is creating the 4th wave in the United States right now. And this is just a plug to remind us about the vaccines, because the vaccines are really key to the strategy. The US strategy is 100% based on trying to limit the replication of the virus. You'll hear analogies. Dr. Osterholm, our own local expert as well, will tell you that the more unvaccinated people we have, the more firewood we have in the forest, as an analogy. So we really want to promote vaccination strategies. Dr. Maroushek is an expert on pediatricians and an expert on vaccines, and she will tell you unequivocally, these are some of the most effective vaccines we have ever seen. These vaccines are incredibly effective in doing their job. So a plug for all of the vaccines. They all work wonderfully. Get the ones that you can get access to.
Yeah, good morning. I'm Dr. Maroushek. I'm a pediatric infectious disease physician at Hennepin Healthcare, and also have a PhD in virology. So this is sort of not something I thought I would mix my two careers in the past, but I guess I am now. I also have children that have been in school, so this is also near and dear to my heart. Dr. Hansen was just talking about vaccines. Vaccines are what we're really going to need to limit the spread and the development of potentially new variants that may be harder to control. I think that's the thing that we in virology are all worried about, is that with continued spread, we may end up with a variant that is even worse than a Delta variant. If you can see, we've been talking a little bit about the vaccines, but what I wanted to show is the vaccine access and where we stand. These numbers are a little old, but within the state of Minnesota, people with at least one dose of vaccine is about 69%, and people with completed vaccine series is about 65, 66%. Now, if you break that down by age group, the groups that you guys will all be worried about, the 12 to 15, 16 to 17-year-olds, you can see that we have about 48% completed and maybe 53% with at least one dose. And we really are working to increase this. Every time we have a child coming in now or a youth coming in for a well visit before school, we've really been encouraging vaccines. We've been giving a lot of them as part of their standard back to school vaccines. And that's what our goal would be in peds. Next slide, please. So with the COVID vaccine projections, there's been a lot in the news lately about boosters, about the younger kids with pediatrics. And we've been hearing a lot even just the last few days. So there is a lot of conversation. There's no real formal guidance yet, other than what we're saying is those with a immune system issue that you should probably get a third vaccine. We're now saying that perhaps after 8 months, we should be getting a third dose if we've had the Pfizer, Moderna. Again, these are all being formalized as we speak this week. We know Israel and some other countries are offering it. This seems to be the way that most of the world is going to be heading. For pediatric vaccinations, there are a number of trials that have begun for children under 12. The first group that will probably be brought up into the vaccine world is the 6 to 12. We were initially hoping by September, but they are trying to increase the number of children in the study to make sure that there are limited side effects, or the side effects aren't necessarily related to the vaccine. I think that's why it's still being delayed. Whenever they see one thing, they tend to really focus on that, and they tend to make sure, is that just something that would have happened randomly or with the vaccine? So they're really doing extra study with this younger group of 6 to 12. After that, they'll probably be doing a 2 to 6 or a 2 to 5 group, and then we'll see from there where we go. We do know that many universities are mandating vaccinations to return back to campus. We have some companies and work groups also mandating vaccines. Next slide. Part of the reason right now that we really want to focus on vaccinating as many as we can, and also going down to the younger age group, is that we know that the younger kids are capable of transmitting. I think early on there was some question about whether kids could transmit or not. But there was a new study that just came out of JAMA Pediatrics that looked at about 6,300 households with children in Canada. And what we found was that kids 0 to 3 actually had a 1.4 odds ratio transmission rate versus 14 to 17-year-olds. What that means in lay terms is that they are 1.43 times more likely to transmit their virus than the 14 to 17-year-olds. And I know most of the group here is in older school age kids, but what's really important to this is that we're going to be seeing more spread in daycare, and the younger siblings are going to have a really greater risk of spreading amongst themselves and then transmitting to the older students, caregivers, siblings, and that's what I think our concern is. Next slide. We know as pediatricians the importance of keeping schools open. This was a study that came out towards the end of last year talking about the impact on children and youth of school closures. The American Academy of Pediatrics actually came out with a policy statement for going back to school, which we will review in a minute, that has really a goal of starting with keeping all the students safe and physically present in school. Schools and the school supported programs are really important for kids' physical, social well-being. Things that we have seen over the last year that have been compromised are academic instruction, social and emotional skills, safety of many students, reliable nutrition. We know many children get one of their only meals a day at school. There is physical, occupational speech therapy for some of our children with special needs, as well as mental health and sometimes even other health services like STI screening in school. And I think the most important thing we've been seeing is opportunities for physical activity. We have seen an enormous increase in pediatric obesity as kids have been home over the last year. Next slide. The American Academy of Pediatrics put out a very strong policy statement about COVID in schools this year. It came out in, I believe, July. Their recommendations are that all eligible individuals in a school setting should receive COVID-19 vaccine. That includes staff and students. It includes adequate and timely vaccination for anybody in the whole school community that might be related to the school. That includes volunteers and other people that might be related to the school. All students over 2 and all staff wear masks while at school unless medically or developmental conditions prohibit. This is the AAP recommendation. We would closely monitor school attendance and absenteeism. One of the findings in this study showed that a lot of schools didn't have a formal way of looking at attendance and absenteeism in the setting of virtual learning, and it's something that they really recommended schools do. The other issue we've had is students with disabilities or chronic illnesses and the loss of the services that are provided at the school. So working closely with those students to see if they have other ways to access some of those services. Behavioral health and emotional support is very important for children, adolescents, and the staff, because the staff are dealing with this as much as the children. And then I think the last and probably most important thing that came to light with virtual learning and COVID is that we have a huge digital divide. There are housing and food insecurities at increasing levels during the pandemic that are affecting most of our students and families, at least where I'm working, and to varying degrees in other school settings. And it's very important that we support that as able. So there's key exposure factors in the school environment that you need to be thinking about as you're developing your COVID back to school plan. Does the setting that the students and staff are in require close contact with people potentially infected? Do specific job duties require close, repeated, extended contact with people with known or suspected COVID-19? How has the community spread of the virus been affecting the school? How many cases are currently in the school? Do we have a way of figuring out that? And these factors are all important to consider in order to really mitigate the risk of infection within the school environment. I'm happy to go ahead and do this slide. I'm not sure who is going to.
No, this is me.
Glenn? I think this is you, Glenn.
Yeah. So as Dr. Maroushek mentioned, one of the challenges here is that we're really not receiving a lot of guidance on the national level, and in some instances, even the local level. So how should we assess our school testing? And one of the things that I want to ask the group is, what is the goal? What are the goals of the school year? What are the goals? And the goals really are to try, there's lots of goals, but the goal is really to try to make sure we can keep our schools open. That's the goal, folks. And so how should we assess school testing? We're going to hear from Dr. Kristine at Orono coming up here as well, and their experiences with their school. Hennepin County was one of the first labs in the state to offer testing to schools. We were doing it prior to some of the MDH programs as well. So these are just some general questions of how we should assess school testing. What percentage of your school is unvaccinated? We know that this represents a greater risk for illness and spread. Are you concerned about the spread at your school and workplace? We can look down south to Florida, which is clearly a different scenario because of the vaccination status. But we also know from recent evidence with the WHO, the World Health Organization, that unless things change, we are not predicting worldwide global herd immunity, which is vaccination status of around 70 to 80% until the end of 2022. So we're going to be dealing with this year. What percentage of your school workforce is between 20 and 35 years old? This has turned out to be a very difficult group to get vaccination rates done in. They tend to consider themselves a little bit impermeable to life's challenges. And so what percentage of your workforce falls within this age category? Does your workforce travel locally, internationally? Do they have elderly at home? Do they have kids at home? Dr. Maroushek mentioned that there's now very strong evidence that children can spread COVID-19. Do you think that testing programs would be of benefit to your workforce? Who is going to pay for this? The state is recently you're going to see it probably this week or next week, come out with their guidance for some of the testing option programs. Many of those include use of the state's free testing options that send your specimens to national reference labs outside of the state. You can ask MDH. Hennepin has been doing testing in schools for a while. Is Hennepin an option? Talk to your representatives, local representatives, if whether or not Hennepin's testing can be part of your school programs. And does your workforce have employees and kids that are currently not provided with the vaccine? These are all questions that go in to your assessment. The panel here is here to help guide you and answer questions. But really, I want to come back to this really key important point. If the goal is to keep our schools open, one of the strategies within that is some degree of routine testing. And the goal is not to prevent cases from happening. We are not going to be able to do that. The goal is to identify cases with surveillance that allow us to keep our schools open. And as I mentioned, Dr. Kristine will expand on her experiences as a superintendent with Orono. But these are some of the questions that we thought we'd pull and hopefully ask discussion points with the group today. So we have a number of options at Hennepin. As I mentioned, we've worked for well over 2 years now on our COVID testing front. We do have saliva as available as a non-invasive sample type. One of the things that is very unique with COVID-19 is the transmission from aerosols, which is why the virus is actually found in saliva. It's very different than what we see with flu, very different than what we see with respiratory syncytial virus. And that's the reason that saliva is now a testing option. We have opportunities for us to do unobserved home collection where you can collect on yourself and use our lab as a testing option. Nasal samples, nasopharyngeal samples, the back of the nose has the best cells where the virus is housed. Those are still the samples that we really do advocate for, but there's a number of testing options. We pride ourselves at our hospital to provide you 24, 40-hour turnaround time. There is no value in collecting a test on Monday that we give you a result for on Thursday. There is no value. So we pride ourselves on a quick turnaround time. We have options for you, including myself and some of the panelists. We're going to hear from Josh as well, who's a very, very talented in his field in terms of his employee health as well. So there's consultants available to you. There's clinical oversight of the programs. There's education that we provide. There's customizable wraparound services for ordering. One of our panelists that's not here today is Kendra Schmidt, who's a lab manager who will hold your hand through the whole process. And like 7-Eleven, the lab is open 24/7, 365 days a year. So these are some of the options that we provide if you do want to have further offline discussions or even part of the group of how testing can fit into your return to school strategies.
Well, thanks for having me this morning. I'm Heather Eastman, and I am a consultant with Gallagher. We do insurance and risk management. And the last 18 months, my job has really been focused on helping organizations navigate this strange time we find ourselves in. As Dr. Hansen mentioned, there is no roadmap, and we're running an obstacle course that's really changing day by day. as we see the announcements coming out from the various school systems and colleges and universities, none of them are the same. They're all different. They're all creating strategies and plans that work for their organizations, or that hopefully will work for their organizations. And so we've been at this for 18 months, trying to figure out if we're wiser. I think we are at this point. Even though there's a lot of unknowns, there are some things that we do know. One of them goes far beyond the disease itself, or the virus itself. And it's not a clinical thing that we've learned, but it's a really polarizing topic. And whether you're, depending on your viewpoints, people have highly charged opinions about this. And I think particularly in the school environment, this creates some unique challenges. Parents are vocal. And for you as school administrators and educators, this is a challenge that goes far beyond your health from a viral perspective. We also know that there's going to be portions of the populations that just will refuse to, or will be unable to be vaccinated for health reasons or for personal beliefs. And we've learned that we're resilient, both in the general workplace. Adults have proven that they have the ability to work remotely and get things done. And children in all grade levels have proven that they are resilient and adaptable. They can learn remotely if they need to. They can learn with masks on their face. They can socialize and compete in athletics with masks on their face. So these are some things that we do know 1 or 18 months in. Some of the things we have been talking with our clients about are, if you are going to be making a mandate about vaccines, there's a number of things that go along with that. Certainly, we've seen some unhappy employees, and there have been lawsuits that have come about. Generally, the trend has been that the court has been siding with the employer that has made the mandate. So certainly something to consider. Again, a highly political issue. Careful review of your policies is really, really important. In particular, if there is a mandate in place, performance management comes into play. And if somebody is refusing to be vaccinated, figuring out the path for disciplinary action for people that are non-compliant is going to be really important for you. So highly encourage you to work closely with your legal counsel to make sure that your policies are up to date and strong and are going to protect you and support you. And then finally, there are going to be exemptions for very legitimate reasons as to why people can't be or won't be vaccinated. And so there's going to be a need, as there has been, to manage that and be prepared for it. There's also going to be turnover that happens beyond, the disease itself. Again, people are tired, they're burned out, they're angry. We are seeing generally in the workforce what we're calling the Great Resignation. And so preparing for both voluntary and involuntary turnover is going to be really, really important. And then finally, I think if there's some positive things coming out of this is when we're in these types of situations, innovation occurs, things change. We're seeing definite changes in values. Things like adaptability, resilience, and empathy are now being considered in core competencies for performance reviews. And we're learning some things about ourselves and what matters to people. So one of the things particularly important for school systems, we're encouraging you to think about your attendance and coverage policies and practices, particularly when we have put such a huge value on perfect attendance over the years. Being mindful of when it's okay to not be coming to work or not be coming to school is really important. So encouraging people to rethink the value of perfect attendance, and also to think about how you might train your staff so that when there are unexpected absences, that there's ways to backfill or cover. Another huge thing that is really important right now is for your staff in the midst of all of this stress to make sure that they're available, that they're aware of what mental health resources are available to them. Your employee assistance program should be highly promoted, and really just doing regular check-ins with the staff to make sure people are doing okay with their own mental health. And then finally, and I think Dr. Flesher will chat about this when she's talking about Orono strategy, there's a huge need for transparency and communication, and almost over communication particularly to parents. Every day we have questions, and I think getting ahead of those questions is really key. So just some things to think about from a non-clinical perspective as we're heading back into the school year.
Good morning, everyone. Thank you for having me. I'm Kristine Flesher, and I'm the new superintendent at Orono Schools. But it's been my 28th year in Orono. And last year, I was also the COVID coordinator and then the director of special services, which includes health services for many years. So I'm here today to share our story and our journey from last year. There was a year of a lot of ambiguity, constant change, fear, and as a result, learning and adaptation. So I wanted to share our health practices that we engaged in and a little bit of our outcome data. The image right here illustrates how we made our decisions and our process for last year, really following, again, lockstep with the Department of Health. Next slide, please. We engaged in layers of mitigation as all of our best practices for health. We had strong COVID coordination. We have an amazing health team, our lead school nurse, Janet Franzen, who's on the call today. Huge debt of gratitude to her. Daily health screening, that was on site. We had that electronically for parents to screen health each day. And for those who weren't screened, then we screened students here on campus. Mandatory facial coverings. We had a lot of training associated for all of our staff with PPE available and for all of our staff. Social distancing, we cohorted students. We started the school year at 6 feet apart. And then the spring we were 3 feet apart, but worked really hard on teaching children about distance. We had a lot of cleaning and disinfection protocols. Ventilation, we were fortunate to have good ventilation systems in our building. But these layers of mitigation were very important for us. Next slide. Our other mitigation was spent on a lot of time on really making sure that the community in the school setting was healthy. So teaching healthy hand hygiene, and as I mentioned before, the screening and monitoring of health. But as everybody has mentioned, we work with Hennepin Healthcare starting in November for weekly saliva screening for our staff. We had the results and huge thank you to Hennepin Healthcare, particularly Kendra and Pearl, for helping our staff. We had staff that were fearful to be in person, particularly previous to vaccines. And the fact that on a weekly basis, they were able to have a screen. And we did that throughout, starting November 3rd, if I recall, all throughout the whole school year. And we'll talk a little bit about the results in a few minutes, but it was a very easy process for us. We had very little on our end, and they provide couriers, and it was an easy and important part of our layers of mitigation. We also took very seriously the red cap surveys and worked really closely with the Department of Health, reporting every case of COVID. We had an entire team of contact tracers that worked very carefully with our families as we were aware and reported for COVID. But a COVID incident command team and followed the decision tree. We had the decision tree posted in all offices for how we excluded students. Next slide, please. Our learning models for last year, wanted to give you a big picture of Orono. We're about a student on the west side of the metro area, about 2,800 students, K-12, so small by metro standards. So we started this school year in hybrid, but our hybrid looked a little bit different. At the secondary level, grades 6 through 12, it was an every other day model with every other Friday for students. At the elementary, we were fortunate to have space and be able to frankly move across the entire elementary complex in order for all students, all of our learners K through 5, were able to come to school, to campus 5 days a week. We did have one section at each grade, which represented about 10% of any grade level choose distance learning the entire year. But everybody who wanted to be in person was in person, even in the fall for our elementary students. We did move to distance learning for secondary students right at Thanksgiving. and then December 1st for elementary students. We did maintain, though, all of our, many of our special populations services in person, even in December, January. So special education students, students with English language learning needs, and our reading students were able to come to campus. And many of those students were students that struggled with either masking or are unable to be socially distanced, particularly our IEP students. And we maintained those programs. We moved back to in-person learning then for our youngest students at Schumann, our K2 students, January 19th, February 1st for 3-5. And then our secondary students, we had our seniors back March 1st and then everyone else on March 8th. So we have experience running in-person learning models. When you think about our youngest learners were in school all but 3 weeks in January, and then all but 3 weeks in December and 2 weeks in January. So we were able to have most of our kids in campus. We felt strongly that kids, to the degree possible, needed to be in school. And those were just some of the outside consultation and process that we used. We worked very closely with our epidemiologists, and thank Susan Clammer, who was constantly a phone call away for us. Next slide, please. This is just an example of how we communicated with our community on a weekly basis about the number of students and our active cases on campus, as well as who had been recovered, and then students that were in quarantine. Next slide. So as we reflect back on last year, what did we learn? Again, just mentioning the weekly saliva testing. We have about a staff of about 350. We tested 150 to 200 staff per week. That did move to single digits as staff were vaccinated in the late spring. But when you look at last year of 2,739 tests through HCMC, we had a small positivity rate, eight staff members. January 4th was the last positive test date. But I would tell you, interestingly, that almost all of the people that were tested positive didn't develop symptoms until either later that day that they were notified or even the next day. So these were people that would have been in the learning environment, and we would not have known that they'd had COVID. Our quarantine data, we quarantined over 2,600 students last year. Again, interestingly, we didn't find clusters related to school exposure. As I mentioned before, we contact traced every single student with COVID, and we could see the clusters and we could see the transmission. We didn't see transmission in school. Very rarely. We saw transmission related to sports, the social activities that surrounded sports, or within households. Our internal transmission that we tracked for all of last year were really just a couple of documented cases that we could definitely say we believed happened in school. You can never for sure say that, but several cases last spring, and then one case this summer. And then last, just as we look at our health data from last year, we worked with the Department of Health and Department of Education, as well as Hennepin County on vaccination sites. So we did have 2 vaccination clinics for adults, and particularly first responders and educators. And we probably have right now about 98% of our teachers vaccinated. And then we also had in the spring another vaccination clinic for our students. Next slide, please. As we look at the recommendations, these are what we have, the recommendations we've had for this summer, and we're still in progress for the fall, but likely to be similar. Again, COVID coordination has been very important for us, for the leadership of our school nurses, daily health checks at home, and then facial coverings have been strongly recommended with, again, PPE continued to be provided for specialized population. Facial coverings required on transportation. Following all of the MDH reporting, again, all of our cleaning and disinfection. Most important has been our message on exclusion of sick children. We will continue to exclude sick children households. We've always done that, strong messaging surrounding that. Again, our social distancing is likely to look similar to what it was last spring. 3 feet in classrooms. We do have chairs placed that far. We're likely to be having lunch both in the cafeteria and outside. We know that we have a spike this fall or in this end of the summer, continued with contact tracing, having the ability to have the COVID testing optional for our students and potential, or for our staff for sure, and potentially students, working with our notification, strong communication with our families, and then recommending those quarantines. We've done that this summer, and our families have followed those recommendations for the most part, and we've been able to not have transmission within the building. So those are our goal is 5 days a week in person with no shutdowns. We want school to be a healthy, we need to protect the learning environment, which is why we need to make sure kids and have a strong message that kids stay home when they have any symptoms of illness. And our hope is for a happy and healthy children. We spent this couple of weeks ago, 2 days just working, bringing in staff on a retreat for social emotional learning, knowing that our children need to be both physically happy and healthy as well as mentally happy and healthy. So that's our story. We have run, I just should have mentioned, we run daycare and summer programming all summer. And again, with our health recommendations, we've seen strong outcomes. So, and I thank you.
Good morning, everyone. Josh Gremlin, Director of Occupational Health, Wellness, and our community vaccine program. And I was feeling very proud about our vaccine rate in our organization until Dr. Fletcher told us 98% of their staff have been vaccinated. Our team is at 88%. So 88% of our staff have been vaccinated against COVID-19. Yet we understand that as not being enough. One of the primary pillars of medicine is that we will do no harm. And one issue with COVID-19 and many infectious diseases, especially respiratory illnesses, is that they're infectious before we even have symptoms. In COVID-19, we understand that folks are infectious a couple of days before they have symptoms. So having everyone vaccinated we feel is key to our strategy to try to prevent any spread within our system. So the way the program has rolled out is that we've given staff 1.5 months to get the first dose, the remaining staff, and another month to get the second dose. Any new hires must be vaccinated at a time that they have their appointment with us, or they don't get to pass on to the next step. That being said, we are required, and it's the right thing, to have exemptions for staff for medical reason or sincerely held religious belief. And we're at the process now of reviewing those for our staff. And so I am going to transition to the other respiratory illness that's fundamental to schools and healthcare. And so I'm guessing just about everyone I know has said to me, man, this was a nice year for not getting a cold. Like with all the social distancing, mask mandates, we also didn't see much flu last year. We had very, very, very few hospitalizations. I've never seen anything like it. And I first became aware of this in looking at pertussis rates, and that's the graph on the right, back in last April of 2020, and looking at this fast trend down in pertussis cases in the state of Minnesota, and was pretty impressed with how effective these are at reducing the risk of illness, the social distancing and mask mandates. And in addition, what happens in school outbreaks. This year will likely look different. Things are different. And I'm sure it's no surprise, I would guess this graph wouldn't be super surprising to educators to know that most outbreaks happen right after Christmas. Kids come back from winter break after spending time with family, and we see these large humps and numbers of school outbreaks in that time period after holidays. Next slide, please. And so in predicting and thinking about this year, it really depends on many factors. I think primarily, we all know that things are loosening up, they're tightening down, loosening up, tightening down, loosening up. But in general, mask mandates in many areas have changed or lessened at least. Folks are going out to concerts, they are going to social events. The state fair is happening. So predicting what will happen this flu season is really a question of how strict the mandates really remain in place. Next slide. One thing we generally use to predict how a flu season will be is how things happen in the Southern Hemisphere. Flu season happens in the South before it happens here in the North, and vice versa. They rely on our data for what happens for their upcoming season. Australia is specifically one location where they do a lot of epidemiological investigation of flu, and we rely on that information. Completely shut down as far as compared to the United States in terms of social distancing and mask mandates. So we have very unreliable data there. Looking at historical, the last year that we had a very low rate of flu in the community in 2011 and 2012, the following year we had some of the highest rates of flu infection following that year. So we know that this last year, almost no one got sick with the flu. Thus, this year, almost no one is immune to the flu that happened last year. So you have less natural immunity that occurs when no one is exposed to the flu. So we have much higher risk in the population of contracting flu, most likely. Next slide, please. So, and so we're really pushing the flu vaccine as a means to try to prevent an epidemic on top of an epidemic. So with the flu vaccine, it varies every year for how effective it is at reducing the risk of flu. But in general, it does decrease the risk of getting the flu by about 50%. Folks who get vaccinated and then get flu actually have a 50% less risk of having very severe illness with the flu. And there's less risk of unknowingly spreading it, as again, you are infectious for at least a day before you actually have symptoms when you get the flu. And importantly, when there's quarantine and restrictions like that, if there's another illness that looks like COVID-19 circulating in the community, there'll be confusion and folks may have to quarantine longer. But in general, if we can limit any other respiratory illnesses, it works in our favor for preventing shutdowns in the schools. And again, on the same track, there'll be less school outbreaks if more staff are vaccinated and students. So we are in schools vaccinating. We in Ramsey County, Hennepin County, in schools around the state actually, and in businesses around the state, we do have vaccine clinics, and we have designated clinic coordinators. They work alongside to help school nurses and others plan and schedule vaccine clinics. We bill insurance directly. For any kids who are not insured, we do have that covered through the Minnesota Vaccine for Children program. And we're very flexible. We do not quite like the lab. We're not at 365 24/7, but we are 7 days and most of the day. And our team comes, provides everything. We have any type of vaccine folks would want to have. And the team is all nurses who go into work sites to provide vaccinations. Thank you.
Well, I want to thank all the speakers today and our panelists for sharing that insightful information. And this slide is just to giving you an overview of some of the services that we have here at Hennepin Health. I won't spend a lot of time on this, but we did introduce last year a new health benefit plan called Clear Value with Medica, provides employers up to 20% saving. And we've talked about some of these other services. Dr. Zadroga, would you want to elaborate more on the travel medicine clinic, since we have a lot of families that potentially do travel? And while we're doing that, I'd like the audience to continue to put in some questions in the Q&A section. We do have some questions, and I'd like to get to that quite quickly because we are running out of time.
Yes, I'll be brief because of the time constraints. Just as a reminder that we have a lot of international families in the state of Minnesota that oftentimes want to go overseas to see friends, relatives, etc. And there's a lot of travel needs outside of COVID and flu, which are obviously very important, but that also means malaria and potentially other vaccines required for travel specifically, and we cater to both children and adults in our travel medicine clinic. So it's just a plug to remind international families that once they live in Minnesota, they are at high risk of acquiring illnesses once they travel overseas again.
Okay, thanks for sharing that. There are two questions that we can potentially answer. These are directed to Dr. Flesher first, and the question is, what did the health screening on site look like at your school?
We used an electronic tool that every family completed every morning that we came in centrally and could look at. For any secondary students who didn't complete that, we sent messages frequently asking parents to do it. But then if they didn't, then we would screen them in health offices. During December and January, we were also checking temperatures for the students that were on campus. But for the most part, parents completed this on a daily basis.
Okay. Dr. Gramling, there's a question for you. The question is, can we vaccinate for COVID and flu at the same time?
Thanks for the question. Yes, absolutely. Since May of this year, as more information has come to light, the CDC changed their guidance to try to separate COVID vaccine from other vaccines, and they can be administered same day, same time, usually use a different arm, but you don't need to separate them at all. They can be co-administered with other pediatric vaccines too, for those at this point 12 and up.
And that's what we've been doing in pediatric clinic as people get ready to go back to school. We've been catching them up on their regular vaccines and then adding the COVID on top of it.
Okay. Well, I want to thank the audience for participating today. And if you have any questions, please do outreach to us. You can reach us at employersolutions@hcmed.org, or you can call us. We'll be sending out a follow-up to this presentation within 24 hours, which will have the entire presentation as well as contact information. As you're exiting today, we'll be asking you to just give us some feedback via a survey. And again, thank you all for participating. Have a good day.